for giving me this wonderful opportunity to speak to you all. I have to say I'm also representing PREMSA UK today because we have this program of sharing experiences or expertise with the Sri Lankan or the Faculty of Medicine, Peradeniya. So with that in mind, when I offered to do this one, I was thinking, what should I do this time? Last time I did something completely different, not related to my pathology specialty. But this time I thought I will do a pathology related specialty, but bearing in mind that the audience is not all pathologists and some are students and some are consultants in other specialties. Then I remembered that recently there is a molecular lab opened in Kandy Hospital by Dr. Palitha, which is a great thing. I went to see it just now. Which is a wonderful thing. So bearing that in mind, I thought, let me just speak a bit about recent advances in molecular markers that are used in diagnosis, in treatment, and also as a prognostic marker. So there are so many molecular markers, and every day there are new markers coming as well. So we are actually finding it difficult to keep up with all the new markers coming to the medical sector. So I can't cover everything. So I've selected a few specialties which actually I'm practicing. So my subspecialties are basically breast. I do a lot of breast pathology, and then I do gynae and GI pathology and lung cancers. So I'm focusing on these ones, and this presentation is not very molecular heavy, and I'm also not a molecular pathologist. So it's more practical what we do in day-to-day life as a pathologist in the UK and what the oncologists are asking and why we are doing all those molecular tests. So hopefully it will be a simple presentation, and also stay awake. There is a live Q&A at the end of this one. Okay. So, so basically what I'm going to do is to introduce what molecular biomarkers are, and to give an idea of most commonly used molecular biomarkers in cancer diagnosis in the UK. And I'm, as I said, focusing on breast, colorectal, gynecological, and lung cancers, and their value in diagnosing, predicting prognosis, and using therapeutic procedures. So before we go into detail, we need to understand what cancer biomarkers are. So cancer biomarkers can be a gene, it can be a protein or any other substance, and it can be tested to reveal details about a person's cancer. So there are many markers available, as I said, and new markers are coming every day. And though there are so many markers, testing may not help all the patients with cancer. But for some patients, it may give useful information about their treatment options and prognosis. So biomarker testing may show whether a cancer is more likely to grow and spread, or cancer treatments are likely or unlikely to be helpful to some patients, if the cancer treatment is working, or a person may be at high risk of developing some types of cancer, or even someone might have a certain type of cancer, though tissue biopsy is the gold standard for diagnosis. And also it can show you if a cancer is likely to return or not. I will show some of the examples as we go. So there are so many names used in the biomarker testing. They all mean the same depending on how you do the test and why you do the test. So they can be called tumor testing, tumor genetic testing, tumor marker testing, tumor subtyping, genomic testing. There are so many words: genomic profiling, sequencing, next generation sequencing. So it depends on what type of test you are doing and how you are doing and why you are doing that. So they all in the end do the same thing. So as I mentioned earlier, even though patients have, for example, say a gastrointestinal cancer, not all cancers are alike. Even in people with the same type of cancer, the genes are different. Different genes affect different morphologies as well. And these changes affect how well a cancer can respond to treatments like targeted drug therapies and immunotherapies. biomarker testing is important as part of precision medicine or personalized medicine. And medical care is tailored based on the specific genes, proteins, and other substances in a person's body. So it goes beyond just choosing treatment based on the type and extent of cancer. So like pathologists, we give in our cancer report, we give a specific cancer type, we give a grade, we give a stage. So those are the basic things, and then margin status. So those are the basic things that we used to do for many years. And then the oncologist would treat based on that report. But now, actually, it has found that not only those features, so it's going down to more molecular level, looking at genetic profile of these cancers to treat and to make them very personalized to people. Though there is so much progress made every day, it's not available for all the cancer types. So there are so many cancer types that you can't target yet, but there are so many other types that we still use targeted therapy. So what samples can be used for biomarker testing? So you can use blood samples, you can use liquid biopsies like peritoneal fluids or acidic fluids. You can use saliva, skin, but I'm not going to talk about those markers in liquid biopsies. I'm just going to talk about the markers that we do on solid tumor samples, which is histopathology. So in histopathology, we make in paraffin blocks. So those sections can be used to test tumor markers. And when we request the test, what we do is we cut more sections or scrolls depending on the percentage of tumor present on the slide. So we have to look at and see how much tumor is present. So we have to give a percentage, whether it's 10% or 15%, 80%. So depending on the tumor percentage on the slide, we decide whether we are going to cut scrolls or sections or whatever. So that's a technical aspect in the lab. Once we cut the sections, we do the molecular testing on the tissue biopsy sample. So in the UK, these tests are done in NHS Genomic Medicine Service. It's a national testing network, and there are large 7 hubs in UK, consolidating all these services into big hubs, because it's not cost effective to do molecular testing in every little lab or every little hospital, because these are very expensive tests. So the funding comes from national funding. So this provides a world-class genomic testing resource, and each responsible for coordinating services for a particular part of the country. So that's so I work at the Buckinghamshire Healthcare NHS Trust. We are part of it's called South 4 Network, which is the 4 hospitals together, and the main one is Oxford. So we are part of Oxford Network. There is a molecular lab in Oxford, and the main one for us is Birmingham, is the big lab. So that's how all the molecular biopsies are coordinated. So starting with specific markers, so I said I will do breast, gynae, GI, and lung cancers. So markers these are the markers that we use routinely in everyday practice in breast cancers. So one is HER2, one is PIK3CA, one is HRD, BRCA, and PDL1. So HER2 is something that I'm sure all of you are aware of, and it's been done for a long, long time. So HER2 stands for human epidermal growth factor receptor 2. So what's new about HER2 then? There is something new about HER2. So there is a new entity recognized as HER2 low breast cancers. So when we test HER2, I think it's the same way that you all do here. When you do a HER2 test, you will get a result as a 0, 1+, 2+, 3+. And when it comes to 0 or 1+, oncologists treat it as negative. So the 2+1, we have to send or do another test called ISH, which is in situ hybridization. You can do FISH, you can do SISH, you can do DDISH, fluorescent immunohybridization, silver in situ hybridization, or DDISH. So any of these techniques you can use to see this 2+, which is a borderline one, is positive or negative. So after ISH test, you can further categorize the borderline HER2, which is 2+, into a positive or negative category. So all this time, and 3 plus is obviously positive. So all this time, even though we gave 1 plus 0, 1 plus 2 plus 3 plus, for oncologists, either HER2 is positive or negative. That's all they looked at all this time. But that's not the case anymore. Because now they have identified some hormone receptor positive and triple negative breast cancers have low HER2. And this category have new targeted therapies available for them. So if you look at this diagram, so as I mentioned, HER2 negative is immunohistochemistry 0. HER2 low is either it's 1 plus or after 2 plus FISH test, it becomes negative. So these are HER2 low categories now, and then obviously HER2 positive category. So HER2 positive category, there is no problem. There is treatment available. And HER2 negative 0, they never treated it anyway. So the new category is the HER2 low category, so that there are treatments now available for 1 plus category and the borderline 2 plus, which becomes negative after FISH. So these two categories are lumped together as a HER2 low breast cancer. Now there are treatments available for these patients. And if you look at this pie chart, you can see up to 45 to 55% of breast cancers are HER2 low. So we never treated this category before, because we treated only the obvious HER2 positive 15%, and then the obvious HER2 negative 30 to 40%. So that large 45 to 55% category now has new treatments coming up. So the next test is called PIK3CA. So PIK3CA is a mutation in the PIK3CA gene, and this can cause cells to divide and replicate uncontrollably. So if it continues to grow of many cancers, including metastatic breast cancer. So this is very important in metastatic breast cancers. And if your tumor has a PIK3CA mutation, new treatments that specifically target this mutation could be used to treat your cancer. So that's another new marker, especially for metastatic breast cancer patients, PIK3CA we do. And also especially if the tumor is hormone receptor positive and HER2 negative, and if they have PIK3CA mutations, there are new treatments available now. So next one is HRD testing. So HRD stands for homologous recombination deficiency. So this is characterized by inability of cells to effectively repair DNA double-strand breakups using homologous recombination repair pathway, HRR pathway. So loss of function of genes involved in this pathway can sensitize tumors to PARP inhibitors and platinum-based chemotherapy. So this is another test now that we do for breast cancer patients. And significantly, HRD increases breast cancer predisposition and tumor aggressiveness. So if you're HRD positive, there is a high risk of tumor aggressiveness. But ongoing extensive research is going on this one. So it's still evolving, but we still do HRD testing. Together with BRCA testing, we do in selected patients if they fit into the criteria, not on all patients. So on all patients, we do HER2. I mean, obviously ER, PR, HER2, we do on all breast cancers. And after that, whether we do PIK3CA is not like in every patient, if they fit into the category. And then HRD, BRCA, these are all not routinely done, but if they fit into the category, we would do. So this is about HRD. Healthy patients with a family risk of hereditary breast cancer can undergo genetic testing for HRD. And if HRD is detected, management options include risk-reducing mastectomy and risk-reducing medications or regular monitoring. So after risk-reducing mastectomy, they can be given selective estrogen receptor modulators and aromatase inhibitors. And also MRI is advised once a year after commencing the treatment to establish a baseline, and with no additional imaging recommended in the absence of clinical findings. Those who are unwilling to take risk-reducing mastectomies, they are monitored with yearly MRI scans and ultrasound scans and 6 monthly or yearly physical examinations. So in the UK, actually, the treatment is up to the patient. So we don't tell what to do. We only give the options to the patient. You have this option, this option, this option. And then we also tell what is the best option for you, but it's up to them to decide whether they want to take that treatment or not. And some people say, no, I don't want a mastectomy. I want to keep my breast. So then doctors can't force them to have mastectomy. So it's their choice, but they need to understand, they will be educated on the effects of that decision as well. So, but those patients are followed up in a different pathway, but they always document patient's choice and what we offered. So after that, whatever happens is patient's responsibility as well. So patients diagnosed with HRD positive breast cancer can benefit from PARP inhibitor treatment and platinum-based chemotherapy regime. So these are the ones that we recommend when we are at MDT, and oncologists are constantly asking for these tests. Next one is BRCA testing. So I'm sure most of you have heard of BRCA testing. People call this is very popular on social media as well. Some people call this Angelina Jolie gene. So BRCA testing, there are two types, BRCA1 and BRCA2 mutations. And we do this one as well, again, if the patient fits into the criteria. So BRCA gene test looks at DNA changes that increase the risk of certain types of cancer. Changes in these genes significantly increase the risk of many cancers. It's not only breast. There can be male breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. So these are some of the criteria that we use for mainstreaming or eligibility for BRCA1 and 2 testing in patients. If the patient has got breast cancer before 40 years of age, we would do BRCA testing. And also diagnosed with breast cancer in both breasts under the age of 50, or triple negative breast cancer under the age of 60, or have been diagnosed with both breast and ovarian cancer at any age, and then breast cancers less than 45 years, and a first degree relative with breast cancer less than 45 years. Then Ashkenazi Jews ancestry with breast cancer at any age, and then non-mucinous type ovarian cancers, including fallopian tube and peritoneal cancers at any age. Male breast cancer, any age. So male breast cancers are also not very uncommon. So I've seen a few. It's not so common as female, but they are not uncommon as well. And increasingly we see male breast cancers. And also pathology adjusted, this is an oncology one, Manchester score of more than 15 or a cancer risk of more than 20%. So these are the criteria the oncologists use to request BRCA testing. So if the patient fits into these ones at the MTT, automatically they say we need BRCA testing on this patient. And patients with BRCA positive outcome, they will have a prophylactic salpingo-oophorectomy as well. And this will reduce the risk of ovarian cancer by more than 96%. So if you keep your ovaries and tubes with BRCA mutation, that means 96% of the time you're going to develop a cancer. And also it reduces risk of breast cancer by 72%. This is with BRCA2 mutation. And also prophylactic surgery reduces the risk of breast cancer by 39% in patients with BRCA1 mutation, and also reduces the overall cancer-specific mortality. So the oncologists or the surgeons can only recommend these things to patients, and it's up to the patient to have it. But the risk is very well known if you keep the ovaries and breasts with BRCA1 and 2 mutations. So the last cancer test in the breast cancer category is called Oncotype DX, which is a breast cancer recurrence score test. This one is actually not done in UK at the moment. So if the oncologist requests it, we have to send it to USA. We send it to USA for testing. So there are two types of Oncotype DX tests. So one is for breast recurrence score test for people diagnosed with early stage estrogen receptor positive and HER2 negative invasive breast cancer. And the second type is the DCIS score test for people diagnosed with DCIS, which is ductal carcinoma in situ. And for students, the ductal carcinoma in situ is the pre-invasive stage of breast cancer before it becomes invasive. So for both of these, oncologists can request recurrence score, and depending on the score, they can predict how likely is the patient going to have a recurrence of the DCIS or recurrence of the invasive tumor. And depending on that, they decide further treatment. So the Oncotype DX breast recurrence score test analyzes the activity of a group of genes that can affect how an early stage breast cancer is likely to behave and respond to treatment. And the test recurrence score test is used in two ways to help doctors to figure out a person's risk of early stage estrogen receptor positive breast cancer coming back in a part of the body away from the breast. So that means distant recurrence. So they can predict the distant recurrence with this score. And also to help figure out if a person will benefit from chemotherapy. So depending on the score, they will have an idea how the tumor is going to behave and what treatment is going to work for this patient. So you may be a candidate for Oncotype DX breast recurrence score test if you are recently diagnosed with stage 1, 2, or 3A invasive breast cancer. The cancer is estrogen receptor positive, the cancer is HER2 negative, and it is node negative, or at least it is in less than 3 lymph nodes. So these are the criteria they look at the MDT, and they can request a Oncotype DX depending on the criteria, and then we send the block to USA to get this test back for patients. Yes, so there is one last one for the breast cancer, which is called PDL1. PDL1 is programmed death ligand 1, and PDL1 is actually not only in breast cancer. There are other types of cancers that we test PDL1. We test it in lung cancer, we do it in urological cancers. So it's done in many cancer types. So in breast, so PDL1 is basically an immune checkpoint protein. So it's expressed in cancer epithelial cells and tumor infiltrating immune cells. So we use the tumor TPS score, which is called tumor percentage score. So you can test PDL1 either in the tumor epithelial cells or in the immune cells. What we use is the one in tumor percentage score. That means if you look at a certain number of cells, say 50 cells, you look at how many cells are positive with PDL1 and the total number of cancer cells, and then you take the percentage. So that's TPS score, and depending on the score, you can use immune checkpoint inhibitors like pembrolizumab, atezolizumab, and nivolumab. So basically, testing is specific for the drug as well. So we do different tests for different drugs. So by blocking immune checkpoints, pembrolizumab and all the other immune checkpoint inhibitors, they unleash the immune system against cancer. So once immune cells are active, they find and destroy the breast cancer cells. So that's how it works. And this is done in locally advanced triple-negative breast cancers and also in metastatic breast cancers. So these tests, as I said, are not done routinely, but very frequently increasingly we are doing more and more of these tests now. And pembrolizumab with chemotherapy is usually given before surgery as neoadjuvant treatment. So these are the list of new cancer treatment molecular markers that we do in our routine practice. So I'm moving on to gastrointestinal cancer markers now. One is MMR or MSI testing in colorectal cancer, MLH1 hypermethylation, and colorectal cancer small variant, which is KRAS, NRAS, and BRAF, and then upper GI HER2 testing. So in the UK, we routinely, in all colorectal cancers, we do MSI testing. So we don't wait anyone to ask, oncologist to ask for it, because it delays only the treatment. As soon as we diagnose a colorectal cancer, once we finish with our immunostains and authorizing, the next step is to cut the block and do molecular straight away. So because that reduces the time for the result to come out. So it's done automatically, reflects in all cancers. So this helps to identify patients with Lynch syndrome, and also there are sporadic cancers as well. So although the majority of colorectal cancers develop via chromosomal instability pathway, approximately 12 to 15% have deficient DNA mismatch repair genes. And it's characterized by the microsatellite instability. That's what MSI stands for. So the tumors with deficient MMR or MSI develop from a germline mutation in MMR genes. So there are 4 genes involved in this: MLH1, MSH2, MSH6, and PMS2. So deficiency in these ones can be linked to Lynch syndrome, or they can be sporadic. And so we do another test called MLH hypermethylation to find out if this is so if a patient, so these are immunostains and we can test, and if all are positive, that means there is no deficiency in MMR genes. If the result comes back as loss of immunostaining in one of these 4 genes, we do further testing. And also these tumors with deficient MMR, on histology, we have distinct phenotype. When we see this tumor, we know that this is going to be MMR deficient. So the morphological features that we see in histology are that these tumors are usually on the proximal colon. And if you look at the tumor is very poorly differentiated, bit anaplastic looking with a lot of necrosis, and then there is abundant tumor infiltrating lymphocytes. So when you see these tumors histologically, you know this is going to be MMR deficient cancer. So the data somehow suggests that some have better stage adjusted survival compared to proficient MMRs or microsatellite stable tumors, and may respond differently to 5-uracil based H1 therapy. So MLH promoter methylation testing is there if there is loss of MLH1 or PMS1. So out of the 4 genes, if everything is positive on immunostaining, that means the patient is proficient for MMR genes. You don't do anything else. But if the most common combination is loss of staining for MLH1 or plus or minus PMS2 genes. So if you have this profile, then MLH hypermethylation test is performed, and this detects the MLH gene promoter area. So this one is useful to distinguish sporadic and inherited colorectal cancers and also endometrial cancers. And the ones that are MLH deficient by immunohistochemistry staining have high levels of microsatellite instability features. If you have sporadic cases, the tumor shows hypermethylation, and hypermethylation is rare in inherited cases. So you can differentiate the two there. But this has to be considered with the other features as well. And in case if the patient has loss of MSH2 and MSH6, which is 2 other genes, or isolated PMS2 gene in immunohistochemistry, that means we are referring the patient to further germline testing for Lynch syndrome. So that's how we, depending on what immunostains are coming up, we do further testing, either promoter hypermethylation or germline testing for Lynch syndrome. We also do KRAS, NRAS, and BRAF as routine practice in all colorectal cancers. And this detects abnormalities in the KRAS, NRAS, and BRAF genes. And this is extremely important for proper qualification of colorectal cancer patients for therapy with anti-EGFR monoclonal antibodies. So automatically, all colorectal cancers are tested for MSI, KRAS, NRAS, and BRAF. And then upper GI HER2 testing. This is again not done routinely. This we do if the oncologists request us only. And these are again more commonly done in gastric or gastroesophageal cancers. And because HER2 acts as an oncogene in this area, and the protein overexpression is associated with genetic amplification of segments of chromosome 17. And then there are tandem duplications of chromosome 17 and double minute chromosomes. So HER2 molecular targeted therapies are now available for upper gastrointestinal and gastroesophageal junction adenocarcinomas. So usually they use trastuzumab with chemotherapy and first-line treatment for HER2 positive metastatic upper GI cancer. And upper GI HER2 testing is different to breast cancer HER2 testing. So it's not the same protocol that we use in the lab. So it's the same test. The interpretation is slightly different because tumor biology is different and they can stain differently. It can be either focal staining or incomplete membrane staining. So the scoring of your HER2 is different in gastrointestinal cancers compared to your breast cancers. So there are different lab protocols to follow. So the next one is non-small cell lung carcinoma panel. So why we are using, I'm using non-small cell lung carcinoma. When you histologically diagnose lung cancers, we divide them basically into two types, small cell carcinomas and non-small cell carcinomas. Small cell carcinoma is morphologically very different, having a high mitotic rate, very small cells, aggressive, there's necrosis, and it's a very aggressive tumor as well, and it's treated with chemotherapy in a different way. So you have to separate histologically the small cell carcinoma from the other non-small cell carcinomas. And the other non-small cell carcinomas have a lot of targeted therapies now available. And the histological types include adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and the mixed types. It could be adenosquamous like. So for this category, there are many targeted therapies are now available. Many types of gene mutations are also present, and depending on the histological subtype, there are so many treatments available. So if you look at this one, it shows how many tests are available. So we do almost all of these, and most of the non-small cell lung cancers are EGFR tested, KRAS tested, and you all have this in your lab as well here in Candid. So EGFR, then FGFR1, ALK, RET, MET, PIK3CA, BRAF, ROS1, HER2, NTRK. There are so many molecular tests, and we do all these tests for lung cancers. Not for the small cell carcinoma, non-small cell carcinoma. And again, it depends on whether it's adenocarcinoma or a squamous cell carcinoma. Sometimes it's hard to remember because you have to remember, okay, I have an adenocarcinoma now, which tests should I do? And I have in front of me all these things because I can't even remember. It's ever increasing number of molecular test requests that are coming to us. So briefly about these ones. So EGFR is a marker that helps to grow and divide cells. So mutations in EGFR is common in adenocarcinomas and is also common in females with lung cancer and also non-smokers. So we learned that lung cancer is basically related to smoking, and the smokers have a higher risk of lung cancer, but there are certain types of lung cancers that are common in females and also in non-smokers. So EGFR can show that. And KRAS is another one, and KRAS is another marker that helps to grow and divide cells. And mutations in KRAS are common in adenocarcinomas. So you can see if we have adenocarcinoma, I would do EGFR, I would do KRAS, I would do NRAS, I would do BRAF. Likewise, depending on the histological type, we do a whole panel. So FGFR1 mutation affects how your cells grow and spread again, and this is in squamous cell carcinomas. And smoking increases the risk here. ALK is a gene, it's actually a 2-gene fusion to create a new one, and it's seen in people who have never smoked, and it's seen in adenocarcinomas. MET is a mutation that causes a glitch that creates too many copies of MET gene, and then it causes cells to live too long and divide and spread. So this is seen in squamous and adenocarcinomas. So PIK3CA plays a role in how your cells grow and divide, and again in smokers and with adeno or squamous cell carcinomas. So as I said, first we identify histologically whether the tumor is an adenocarcinoma, and then we request the whole relevant panel. And if it's a squamous cell carcinoma, then there is a separate panel. Likewise, different panels are used depending on the histological subtype. BRAF is again common in adenocarcinomas. ROS1 is similar to ALK, and NTRK mutations. There's a fusion with other genes, and men and women both of all ages, and in smokers and in non-smokers. So everyone can have an NTRK mutation, irrespective of the histological subtype. RET is again another one in adenocarcinomas, and HER2 mutation encourages again growth of cancer cells, and mutations are common in adenocarcinomas and in women who have never or rarely smoked. So interestingly, so lung cancer is not only in smokers anymore. Non-smokers also get lung cancers, and males and females as well. So targeted therapies like monoclonal antibodies that attach to certain targets of cancer cells and destroy cancer cells are now available. So that's why we are testing so many molecular markers. So otherwise, why do we do them? These are very expensive tests. So because the oncologists can target the treatment depending on the mutations they have. And then there are small molecule drugs that are small enough to enter into cells to stop the cells dividing. So there are so many emerging new drugs every day in clinical trials that can target these mutations. So this is the personalized medicine. So going beyond the diagnosis of histological type and stage, we are going down now to the molecular level to identify specific gene mutations in a specific patient to target those and treat. So it's becoming that personalized nowadays. So last one is endometrial cancer panel. So like 15 years back when I was in UK, we didn't do anything for endometrial cancer. So most common type is the endometrioid type endometrial carcinoma. That's all we say. It's a grade 1, grade 2, or grade 3, depending on the histological type and the solid areas. And it was understood that if you say grade 1 is prognosis-wise, grade 1 is better than a grade 3, because grade 3 means you have more solid areas. So it's graded depending on the solid area. Grade 1 is less than 5% of solid areas. Grade 2 is 5 to 50% solid areas. Grade 3 is more than 50% solid areas in an endometrioid carcinoma. So the more solid areas you have without gland formation, we think it's poorly differentiated, and the prognosis is going to be bad. So this is what we thought previously, but actually that's not the case anymore. So therefore, nowadays, we routinely check all endometrial cancers for ER, P53, MMR. These three we do routinely, and depending on the test results of these, we do poly mutation. So ER is scored like in any breast cancer out of 8. So some cancers are ER positive, negative, depending on that, we can give treatment. And P53 mutation, so there are two patterns. One is called wild type, where the P53 stains with heterogeneous staining, some strong staining, some less strong, some are negative. So when you have the whole spectrum, you call it P53 wild type. And then some tumors are P53 mutated. So you get completely strong 100% staining, or you can have null types as well, no staining. So P53 mutation shows the aggressive phenotype. And MMR testing is done exactly like in colorectal cancers. So again, in endometrial cancers, defects in mismatch repair lead to high mutational burden and the abundance of new antigens and profound immune response, making the endometrial carcinoma an ideal target for immune checkpoint blockade therapy. So depending on histology and about test results, we do poly testing. So I'll show you an algorithm for poly testing. Poly is a DNA polymerase epsilon and tested by next generation sequencing. There are 11 mutations found to be pathogenic. So this is something that I never remember. So again, I have it in front of me. I have to always look into this one to make sure that I do the correct thing. So I don't know if it is clear enough on this one. So in the first category, on the biopsy, we do MMR, P53 and ER. And if the tumor is MMR abnormal and no P53 abnormal, then we request poly mutation. That's all we do on biopsies. When it comes to the excision, you can see, again, depending on the whether there is lymphovascular invasion in the tumor, or if the tumor is a higher grade, or if the tumor is any other subtype, we will request poly mutations. So this whole algorithm we follow depending on whether it's a biopsy or an excision. Not all patients, that means, get So basically, low-grade tumors will not get polymutations, but if there is any abnormality in MMR or P53 or a higher stage, higher grade cancers will get polymutation tested. And the interesting thing about polymutation is majority of the polymutant endometrial carcinomas are endometrioid carcinomas. And we know most of the endometrial carcinomas are histologically endometrioid subtype. And there are serous carcinomas as well, and in other types. So despite most of these tumors having high risk features such as high grade, like grade 3 and lymphovascular invasion, molecular subtype with polymutation has exceptionally favorable survival outcomes. So this is something that the histology and the molecular things don't go together. So they can look histologically very high grade with lots of lymphovascular invasion. These are all poor prognostic factors we used to think, but actually if they have a polymutation, they are going to have a favorable outcome. So recent guidelines said that stage 1 and 2 polymutated endometrial cancers are low-risk tumors, and that women with stage 1 or 2 pathogenic polymutation endometrial carcinomas, we can stop adjuvant therapy, or you should consider not giving adjuvant therapy if they are polymutated. So that means identification of pathogenic polymutation in some patients will allow us to discuss de-escalation of adjuvant therapy and identify patients who are eligible for de-escalation clinical trials, and these patients may be spared from the toxicity and the cost of unnecessary radiation treatment and chemotherapy. So that means what we thought previously high grade morphologically and with lymphovascular invasion, we are over treating most of these patients. And if they are polymutated, you can stop adjuvant treatment and not give them unnecessary treatment, because we know chemotherapy, radiotherapy, they are all toxic. So you can de-escalate if they are polymutated. So that's an interesting one. So when you go down to the molecular level, everything that we thought previously on histology is not correct anymore. So that's all I think I had time to cover. So I think I hope it was of any use to someone, and if you have questions you can ask. So I just put this one to just as I said, I'm representing PEMSA UK, and there are some medical students as well. I just wanted to highlight that we have introduced a couple of new awards and scholarships and bursaries. So one is PEMSA UK Professor Jayasena Student Bursary and a Pharmacology Award for 2024. And the bursary is 6,000 rupees per month for 60 months. And so we are giving it every 5 years. And there's a Pharmacology Award of 20,000 rupees with the certificate given to student who has displayed outstanding academic performance in pharmacology. And then also there are the usual previous research grants available for students and postgraduate doctors as well. So there are lots of things available through PEMSA UK. You can apply and get selected to do this. So that's us for the PEMSA UK. This photograph was taken last year, November, when we had the International Academic Conference and dinner dance at the University of Oxford. So I'm currently working as the secretary for PEMSA UK. So that's all from me, and I hope it was useful. And I created a little live Q&A, and let's see if we can do that. But you need to connect your phone to this one, and shall we give it a try? It's a very simple one. So if you can... I can't see the code here. Can you scan the QR code? There is a... Let me go back. Or if you log into on your smartphones, it is covered on my screen. I can't see the number. So if you either you scan the QR code, or you can just Google menti.com, menti.com, and there is a place to put the code. This code is 81633661. If you put the code, you will connect. I'm getting some answers already. So hopefully you can. It's a little fun one. It's a very easy one. Just try and do that. You can either scan the QR code or you can use the code. You have to Google menti.com and put the code 81633661. Ready? Let's give it some more time. Somebody's done already. Shall we start? Shall we give it a try and see? Yeah, some people are responding, I can see. Ready? Okay. Right, so the first question is, which one of the following samples is not routinely used for cancer biomarker testing? Blood, saliva, feces, skin. This is to check if you're awake or is just falling asleep. So I got 4% say saliva, 83% saying feces, and 13% skin, and still more answers coming. Done? There's still more coming. So which one is the, yes, which one is the correct answer? Still more coming. So I think you got the answer. Feces is the one not routinely used for cancer biomarker testing, but who knows, maybe there will be tests coming in feces as well. So there are more inflammatory markers that we test in feces, like in inflammatory bowel disease, you check, what is it called? Calprotectin. Calprotectin is something that you check in feces in inflammatory bowel disease, and that's high levels of calprotectin, I think above 150 or 100. So if you have in 600s, 800s, that's a marker of inflammation in the bowel. So you may be able to do, and maybe there are things as well, but routinely we are not doing anything on feces, but skin, saliva, yeah, body fluids we can use for biomarker testing, but my talk was on tissue diagnosis. Okay. So the second one, which one of the following is not a biomarker of breast cancer? HER2, POLE, PD-L1, and PIK3CA. Didn't get it wrong. Yeah. All done? Yeah, so I've got 29 people saying POLE, and that's the correct answer, right? So HER2 is tested in breast cancer, we said in upper gastrointestinal cancers and some lung cancers as well. And everyone knows breast cancer and HER2. And PD-L1 is in lung cancers, urothelial cancers. We do PD-L1 in breast cancers as well. And then PIK3CA in breast cancer and in lung cancers. But POLE mutations I mentioned only in gynecological or endometrial cancers, isn't it? So it's not a marker of breast cancer, at least for now, as we know about it. So 32, yeah, great. Everyone was awake. The next one is, which of the following cancer type is not linked to BRCA mutations? So I mentioned a couple of tumor types linked to BRCA mutations, BRCA1 or 2, So not linked, breast, ovary, prostate, skin. Yeah, I think that's it. So we got all saying skin cancer. That's correct. So breast can have BRCA mutations, ovary can have BRCA mutations, prostate as well. I didn't talk about prostate and the urology, but I mentioned prostate in my presentation. So skin is the one that we are not, we don't know at the moment, at least, if there are any BRCA mutations, and we don't test skin for BRCA mutations. That's great. And the last one, which one of the following biomarkers is not included in the lung cancer small variant panel? So one of these is not routinely tested in lung cancer. MLH1, PDL1, ROS1, EGFR. Having a bit of a problem with that one. So, so PDL1 is one of the main markers that we do in lung cancer. And ROS1 is as well. So I remember I showed a pie chart. It had so many things in it. But EGFR, ALK, PDL1, ROS1, they are the main ones we test in lung cancer. So the one that is not tested in lung cancer is MLH1, because MLH1 is part of the MSI testing. So MSI testing we don't do in lung cancer, at least for now. Okay. And I think that's it. Oh no, there is one more. Okay. Just get rid of this one. Yeah. Which one of the following predicts the recurrence rate of breast cancer? Poly, PMS2, oncotype DX, PDL1. I thought the lecture was going to be boring with molecular stuff, and I tried to keep the moleculars to the minimum and included more practical side of what oncologists do. So I think somehow people were listening. Yeah. So it's not poly, it's not PMS2. PMS2 is marker of, it's one of the MSI tests. Poly is the endometrial one that I told about. And PDL1, as I said, is in breast, in urology and urothelial cancer and lung cancer. But oncotype DX is the test that we use to check for recurrence rate. And this is the one I said we send to USA. We don't have the facilities to do it in UK. So this one gives the recurrence rate of breast cancer. I think that was the last one. Yeah. So thank you very much for listening. And I hope you'll gain something out of it. And it's really difficult to cover a topic like this in 45 minutes. So I chose a few topics and hope it was of use to someone. Thank you very much.